It is common knowledge within the deaf community that deaf individuals experience major barriers when attempting to access healthcare. For example, some patients are not accepted into clinics, while others are denied access to an interpreter, even when a request is made. Requests are often made for an interpreter to have access to basic healthcare information, but many clinics still deny this request. Therefore, people who are deaf often receive healthcare without any access to communication. This results in a lack of knowledge regarding their overall health. Because of this lack of communication, deaf patients are unable to fully express their concerns to their healthcare provider, which leads to misdiagnosis and underdiagnosis of their healthcare needs. We now know that deaf people do experience these forms of discrimination. Deaf individuals deserve to be accepted as patients, have full access to communication, and be able to participate in their healthcare. Hello, and welcome here to the interview with the panelists. First, I'd like to introduce myself. After that, we'll introduce our other wonderful panelists. My name is Stephen Snow. I'm the Executive Director for the Idaho Council for the Deaf and Hard of Hearing. I also supported this research project. We had a wonderful team and they're here with us. We'd like to take the time for them to introduce themselves so you can get to know them and their background better. Let's start with Dr. Schniedewind. Would you go ahead and introduce yourself and tell us a little bit about your background?
Hi, I'm Elizabeth Schniedewind. I'm not deaf, and I'm a clinical associate professor in the Sign Language Interpreting program at Idaho State University. Our college specializes in health sciences, and I've specialized in medical interpreting in a variety of settings for many years. It was because of that connection that I started researching accessibility for deaf patients related to interpreter services.
Thank you very much. Now, Dr. Lindsay, would you mind telling us briefly a little bit about yourself and your background?
Sure. My name is Ryan Lindsay. I'm an associate professor at Idaho State University. I have a PhD in public health and my emphasis is in epidemiology. I've always been interested in health disparities and how different health outcomes occur with different groups of people. My interest in study design and audit studies led me to collaborate on this great project.
As we recently mentioned, the deaf community often reports experiences of discrimination when trying to access their health care. And now we'd like to take a look at the research to help us to better understand this important issue. Dr. Schniedewind, can you tell us a little bit why we chose to research this issue and what the objectives were?
We had very clearly defined study objectives. The first one was to compare the rate at which patients who were deaf or hard of hearing were offered primary care medical or dental appointments with the rate that appointments were offered to patients who could hear in a real-world context. The real-world component of the research design was essential because there were reports from deaf patients regarding the difficulties they experienced in securing healthcare appointments and receiving interpreter services at those appointments. Idaho State University and the Idaho Council for the Deaf and Hard of Hearing have had a successful and productive working relationship, which we leveraged as a research partnership and allowed us to document the incidence and severity of these barriers for deaf patients. Our study took an experimental approach in order to assure accurate reporting.
So with this research project, it had its own design. Do you mind telling us a little bit about that unique design?
Our study was cross-sectional and that means that a specific population was investigated at a point in time. It had an audit study design. Audit studies are experiments where two different groups of people participate in the same activity, and in our case, this was calling healthcare offices, and then the results of the activity are compared.
Thank you very much. So, Dr. Lindsay, I have a question for you. You're considered the go-to guy when it comes to statistics and numbers. When it came to this specific project in the sampling frame, there were over 400 clinics, both from dentistry and medical primary care. So from your perspective, how was that number of over 400 clinics determined? And how were each of those clinics identified to be a part of this study?
Well, we arrived at our sample size through a sample size calculation where we wanted to make sure that we had enough clinics involved that we could detect subtle differences in success rates for making appointments between hearing and deaf individuals. So that's how we got the overall size, but within that sample we wanted to make sure that certain groups we had a sufficient sample for. So it's a stratified sample where we had at least 20, we want to have at least 25% of the clinics be dental clinics. That came from focus group data that we had that showed that dental clinics were particularly a struggle for deaf individuals to acquire interpreters. So that's why we have dental clinics mixed in with primary care clinics. Those the list of clinics we got from board certification lists for both respective primary care clinicians and dentists, and then we randomized within that sample frame to make sure that we had less bias in the way we selected clinics and that our results could be more generalizable. We also made sure we had clinics from around the state. That was because we wanted to be able to detect any differences between urban and rural settings, and also have a geographic distribution that we could say was statewide. And so we achieved that sample, and that's how we arrived at it.
Thank you. So for the study, we were able to recruit a total of 8 people. They are called simulated patients. 4 of those simulated patients were individuals who could hear, and the other 4 were deaf. Those simulated patients made phone calls to clinics. The deaf patients called through a video relay service. We provided training to all 8 of those simulated patients how to process calls for this type of task. Now I have a question for Dr. Schniedewind. For those simulated patients, would you be able to tell us a little bit more, kind of what the process looked like and what was involved in this kind of task?
Yes, the study protocol for the simulated patients who could hear and the simulated patients who were deaf was similar. For most of the task, or a large portion of it, when they were requesting the appointments, there was a script that both of them used. When the hearing patients documented the result of their request for an appointment, they were done at that point and their task had ended. However, for deaf patients, their training continued past this point, because once deaf patients were offered an appointment, then they requested a sign language interpreter to be provided at that appointment. Then they documented the results of asking for an interpreter. We also included training on the type and the amount of self-advocacy that the deaf patients would engage in as part of their request for the interpreter services, if their request for interpreter services was initially denied.
Thank you. You know, we have used a community-based approach when it comes to research projects like this. I wanted to ask you, why is that participatory approach so important?
It's impossible to overstate how critical community-based participatory research is to ensure that the experience of deaf people is reflected in research goals and in procedure. The perspective of deaf patients would not be accurately represented by researchers alone, as we cannot fully appreciate the significant differences without guidance. An example of the benefit of the community participation was when community members highlighted the need to investigate access in dental offices, as well as the primary care offices that we had planned to study, because there were access challenges in the dental setting that were being reported that if we had not discovered that with the participation, we wouldn't have been aware of and couldn't have addressed.
Ryan, I have another question for you. From our simulated patients, they made a total of 1,096 calls. They reached out to over 400 different clinics, both dentistry and medical primary care. So from your statistical analysis perspective, would you be able to share with us, how do you process and analyze that data to get results? And secondly, what kind of variables are involved?
First, there are more calls made than there are clinics because there are many, some clinics needed to be contacted multiple times. So that's why there are that many calls. First, we wanted to document what was happening in those calls. And so we, both for hearing simulated patients and deaf simulated patients, documented whether or not the call was an accurate number, whether or not they were told that the clinic was accepting new patients, accepting their type of insurance, and specifically for the deaf simulated patients, we were very interested in documenting whether or not an interpreter-related reason was given for not securing an appointment. Then, in terms of the data analysis, we did first an analysis looking at just a comparison of each clinic that had a simulated patient call it, a hearing simulated patient call it, and a deaf simulated patient call it, and that one-to-one comparison just to see if there was any disagreement in whether or not the simulated patients were able to secure an appointment. With that analysis, we were also able to take into account things like the urban-rural status of the clinic, sex of the simulated patient, male, female, and type of clinic, geographic area. So all of those we could look to see if those played a role in the success of having an appointment secured. We did another analysis just looking at deaf simulated patients that were unsuccessful in getting an appointment. And in that analysis, we compared those that had an interpreter-related reason for not securing an appointment compared to all the others that were given other reasons for not having an appointment. And that was an interesting analysis because we could then also take those same demographic variables, sex, geographic location, urban-rural status, type of clinic, and also see if those factors were related to being given an interpreter-related reason for not securing an appointment.
Oh, thank you. I have another question. Were there any limitations in the sampling?
There are always limitations to any study, including this one. And one limitation is that we only sampled folks in Idaho, so our findings can't be generalized to broader populations. However, we feel it is strong that we were able to achieve a randomized sample across the state that included various types of clinics and urban-rural areas. We also, a limitation was that some of the clinics we called needed to be excluded because of protocols for simulated patients that weren't followed, or at times the clinics weren't able to create or make an appointment during the time frame that we were wanting. Another limitation is just that the fact that we only got verbal acceptance of an appointment, and we weren't able to actually send a simulated patient to the clinic to see if an interpreter that was promised would actually be provided. And again, from focus groups, we know that's an issue, and that's an area for future research.
Elizabeth, I have a question for you. So, what were your result findings? Within those, what did you notice? Was there anything that was surprising? Maybe why an appointment was unsuccessful? Can you tell me more?
The most significant finding was that simulated patients who could hear were more successful in securing new patient primary care and dental appointments than were deaf simulated patients. Hearing patients were offered appointments almost 65% or 64.4% of the time, while deaf patients were offered appointments a little less than half of the time, or 49.1%. This means that hearing patients were almost twice as likely to succeed when securing new patient appointments than deaf patients were. And when patients were unsuccessful in securing a new patient appointment, the reasons these requests failed were different for deaf patients than they were for hearing patients. Almost half of the time that deaf patients were unsuccessful in securing an appointment, or 48.2% of the time, the reason for that denial was associated with the request for interpreter services. You'd asked me about results that were surprising. One finding that stands out relates to self-advocacy. For some time, deaf patients have been encouraged to advocate for themselves to receive the services that they need for access, but this study suggests that that approach may be less successful than we previously thought. More contacts with a clinic did not increase the chances that the deaf person would be promised interpreter services.
Thank you. Now I have a follow-up question for Ryan. Were there any limitations in the result samplings?
I think one of the biggest limitations to this study is we were only able to detect whether or not there was a verbal promise of an appointment. We know from a previous study that we've done that a lot of times the breakdown in this process is that interpreters are promised but not actually provided when deaf individuals show up at the appointment. So this study, we weren't able to follow through all the way to send the simulated patient to the appointment, and that is a limitation.
Wow, this is a fascinating discussion so far. So I'd like to open it up. With looking at the results of this study, what kind of impacts will a study like this have on the deaf community, or even within the medical healthcare profession? Does anyone want to comment on that?
It is our sincere hope that the research will encourage more clinics to provide interpreter services when deaf patients request that. Our study should also help clinics take a more holistic approach to education regarding the obligation to provide access under the Americans with Disabilities Act. In our study, the importance of awareness on the part of especially frontline staff is highlighted. Denials of those requests for interpreter services were made by a variety of personnel, including frontline staff.
Well, if there are no other comments, I do have a question. With a research study like this being published, do you feel like it will open the door for potential research studies in the future?
I think so. I think first we have to look at the findings that we have and just note that these are findings that those in the deaf community have lived for a long time, and so this validates them to see empirically measured, but it also is a study for those that can hear to open their eyes to something that they may not be fully aware of, that really does impact access, something as basic and as important as access to primary care. So in terms of future directions for this study, I think one would be to look at how does this barrier, this challenge to accessing a simple appointment to establish care, how does that actually impact health outcomes? Other studies have shown that, but can we actually document among simulated patients or even real patients that have real health conditions what the impact is of not being able to make an appointment? I think there's other future directions too in terms of interventional research. What we found is, you can't point at one person in the clinic. You don't know who's answering the phone. It really needs to be, there needs to be education and training in the clinic environment. And with that, training to see if we can be successful, because there already is a policy framework and that deaf individuals can use to get interpreters, but that is not always being honored. And so it really does, in my view, point towards the need to do that education in the clinic.
Wow, this discussion has been very interesting. Talking about the future, it really will be interesting. I feel like this is opening opportunities to improve access within the healthcare system for the deaf and hard of hearing community. Thank you both so much for your time. I hope you all enjoyed the comments and discussion today. Our study provides the first apparent verification, to our knowledge, of the discrimination experienced by deaf patients when requesting a sign language interpreter for their healthcare appointments. This statewide sample shows that deaf patients had significantly less access to basic health care when compared to patients who could hear. The most common reason deaf patients were unsuccessful in securing an appointment was due to the request of sign language interpreting services, even when these interpreting services would have been required for effective communication. Training of clinical staff may result in improved access to healthcare for deaf patients.